Okay, so thank you so much for the invitation. I'm really delighted to be here. I attended some of these webinars here like last year, not this year, unfortunately. But the talks I attended to were always very exciting and thought-provoking. So it's a real pleasure to contribute to this today. And treatment expectations are central to much of the work that my lab and I are doing. So today I'm going to present some of the questions that have been motivating our recent and ongoing work, which I think and hope suggest some novel approaches to treatment expectations. I'll start by saying that there is now a large body of evidence showing that treatment expectations can shape clinical outcomes and contribute substantially to placebo effects. And much of the field has focused very productively on measuring these expectations and testing how strongly they influence symptoms, treatment responses, placebo effects, etc. But I think there are still several important gaps in our understanding. First, how expectations are actually generated from complex information. For example, when people receive social, statistical, clinical information about a treatment. Second, how are treatment-related beliefs updated when people encounter new evidence or new information? For example, hear about cases where symptoms improved or did not improve with specific treatment, etc. And third, how can we use this knowledge not only to explain placebo effects or treatment effects, but also to intentionally and ethically enhance clinical outcomes? So the overarching question for this talk is this: how can we move from measuring treatment expectations to modeling, shaping, and clinically leveraging them? And I will address this, like Jenya mentioned, in 3 parts. First, I will ask or talk about expectation generation, how people construct expectations about pain and visual stimuli from complex social information. And then I'll move to treatment-related beliefs from a belief system perspective, which I will explain, focusing on how beliefs about treatment, illness, recovery may be updated together. And finally, I will present some current work that we have on personalized placebo effects, this is how I call it, where we ask whether treatment communication can be tailored to different individuals in order to enhance their expectations and ultimately the clinical effect that they will gain with treatment. So I'll start with the first one, how expectations are generated. And many Bayesian and predictive processing accounts focus on how expectations or prior beliefs combine, right, with sensory information and input to shape perception. This has been extremely influential in placebo effect and pain research and way beyond that. But I want to take one step back from this research and focus on the prior itself, or the prediction, the expectation itself, and ask how these expectations are generated. And one way in which we studied that in a study that we published last year was using social distribution cues. These are the cues. They're basically showing the scale that the participants use in the study to rate the stimuli. We have both painful stimuli, which are thermal stimuli, and visual stimuli, which are flickering checkerboards, and that people need to judge their contrast. And each one of these cues, you can see here the scale, and you have 10 different lines on that. And we tell participants that these lines represent ratings by previous participants. The 10 previous participants who experienced this stimuli, this is how they rate this specific stimulus that is about to happen. Of course, this is not true, okay? We manipulate these values. And what's nice about these cues is that we can manipulate orthogonally, independently. We can manipulate the mean here of these 10 lines in each cue. For example, it could be lower or higher or different levels. We can manipulate the variance or the standard deviation, which can be very narrow or very wide, right? More or less certain. And we can manipulate the skewness, meaning the outliers. We can have a distribution of here, for example, there are some outliers more to the left, to the lower side. Here there are outliers more to the right side. We can have a symmetric distribution. We can manipulate where outliers are present. And one important thing about these cues in this study specifically is that we use them in a way that is not reinforced, meaning that there was no conditioning made between, for example, low mean and low stimuli, or high mean and high stimuli, or anything like that. It's all cognitive and based on suggestion, right? On seeing this cue and reasoning about what, constructing your expectation from that. What this allows us is to ask which statistical aspects of the information people use to construct their expectation. And we can also compare across domains, at least these 2 domains, visual and pain. The full paper also concerns how expectation affects perception, so people experience the stimuli and rate them, but I'm going to focus today only on the expectation part. Okay, if you want to see more about neural mechanisms and things like that, you can look at the paper if you want, or ask me later. The experiment included 3 tasks. The first one was a stimulus response. Oh, sorry. It was a stimulus response task in which they experienced the stimuli, either pain or visual. There were different blocks, and just rated them. This was more to like familiarize participants with the stimuli, make them used to the scale, just give some context to our experiment. The second task on which I'm going to focus today is the expectation task. And here participants saw multiple cues, each one at a time, of course. They saw a cue like that, as I explained before, where we manipulate different 5 levels of the mean and 2 levels of the variance and 3 levels of the skewness. And then they just report their expectation. They do not experience any stimuli in this task, but again, they're already familiar with the stimuli from the previous task. And there was a third task in the MRI scanner where they saw the cues, experienced the stimuli, and then rated. But I'm going, as I said, multiple times focus on this expectation task. And what we wanted to see, we expected people to be strongly influenced by the mean. This is what's usually done in the field, right? We have high or low cues. Sometimes we condition them, sometimes we don't. But we expect people to have higher expectations following high cues versus low cues. And the high and low here is basically the mean value of these 10 different Q values, the 10 different lines. But we're also interested to see what would happen with the variance, the certainty of the Qs, and the outliers, okay, where the outliers are located. Is it either it's symmetric or we have positive or negative skewness? And what we found was, first, as expected, that there's a strong effect of the mean. So people's expectations were strongly driven by where the mean of the Q was. We have pain here and visual contrast here. We have the expectation rating on the y-axis and the Q mean on the x-axis. And you can see that the larger the Q mean, the higher the expectations that people reported. This was very much expected. But we also found that people were affected by outliers in their expectation construction. So if the distribution was more positively skewed, meaning there were outliers to the upper side of the scale, people reported higher expectations compared to if the distribution was symmetric, and then lower expectations when the distribution was negatively skewed, meaning outliers were to the lower side. So expectation was biased towards outliers, okay? And just to remind again, it's orthogonal, so the mean is the same. It's the same mean, but there are outliers more here or more there, okay? With regard to the variance, we found some interesting results too, which were more domain-specific and more complicated. So I'm not going to get into this now because I want to get to other studies, but we can talk about it later if you want. To test this more directly, we use a computational model, which tested how participants weight each of the 10 Q values, if each of the 10 lines in a given Q. We wanted to see if they equal each one of them, if they weight each one of them equally, so each one gets the same weight, or maybe they overweight specific values. And we wanted to estimate 2 different ways in which people might overweight values with 2 free parameters. One estimates whether people overweight values based on whether they're inliers, more close to the middle, or outliers, farther from the middle. And the second one tests or estimates the weight of each Q value based on whether it is smaller than the mean of this Q or larger than the mean of this Q. Because we reasoned that people might be more influenced by, for example, by outliers or inliers, and by maybe only outliers to the upper end or outliers to the lower end. What we found with this model is that people overweight outliers in both modalities, both pain and vision. Okay, so they give more weight, they're more affected in their expectation construction from outliers, just like we saw in the linear models that I showed you before. And quite surprisingly, we also found that only in pain, people were more affected by the lower values, so values that were lower than the mean and not the higher ones. I have to admit that we were kind of surprised. We thought that actually in pain, because it's more aversive and more of like a risk signal, we thought that people will be more attentive to the higher bound of the scale. But maybe what happened here, one potential explanation is that this study was done with healthy participants who volunteered for a pain study. And maybe people that volunteer for a pain study consider themselves less sensitive to pain. And then if they see a distribution of here or other participants how they rate the stimulus, they might think, well, I'm not sensitive to pain, so I'll be like the people who are not, think it's lower than the others. This is a speculation completely. And it may look different in another sample of healthy participants or in pain, chronic pain or anxiety-related samples. I don't know, I didn't test it, so just putting it there. But this is what we found here. Sorry, the arrows are not supposed to be here. But I think what's more important here than the specifics of, whether they were more affected by outliers or inliers and lower or higher values, I think what's more important is that expectation generation is not just, noisy averaging. It's a process of constructing from the expectation from complex information. It can be domain sensitive or context sensitive. And from a broader point, if we want to understand treatment expectations, I think we need to ask how expectations are constructed. I think we need to focus on this question in general more than we do now. And in real treatment context, people, they don't receive just simple low or high cues, right? They receive very complex information. It can be social information. Here it was, basic ratings by previous participants, but it could be testimonials, other patients telling them, about the treatment. There is statistical information about, how many, the information you got, the mean, the specific, maybe you got a specific testimonial, which is very different than the others, an outlier or not. And maybe, people say pretty much the same thing about the treatment, or maybe they say very different things. This is the variance. You get the clinical explanation, the mechanism, the evidence. You have your internal information, your prior experience, past treatment, your beliefs about your body, your clinical history, etc. And you interpret all of this within your existing beliefs that you already have, right? About the illness, about your body, about the treatment, etc., or treatments in general even. So expectation generation itself, I think, should be a research target. And this is what I want to deliver here in this part. Okay, so this first study was about how people generate expectations for information presented at a single moment. But real treatment context, expectations are not generated in isolation, right? They're embedded in, like I just showed, in broader systems of beliefs, right? About the situation, yourself, the illness, the treatment. So the second question that I want to ask is, how are treatment-related beliefs updated? And here I say beliefs and not expectations as kind of a broader construct, but expectations are part of, right, of treatment beliefs. If my expectations about treatment is my belief about whether it would work or not. Okay, so it includes expectations. And in real treatment context, new evidence is often ambiguous. Okay, I'll give you an example. If you read this vignette, Sarah is a 63-year-old woman who may have COVID-19. She has a fever of 38 degrees Celsius and difficulty breathing. She's at home and has not previously been tested. Sarah enrolls in an early-stage clinical trial testing the safety of a new antiviral drug for COVID-19 and takes the drug daily. She also takes an additional over-the-counter drug that she read is thought to be effective for COVID-19, and within 5 days, all symptoms disappear. In this vignette, there is an attribution problem. Okay, if I ask you why did Sarah recover, there are multiple possible explanations here. Right? Maybe she recovered because of the new antiviral drug. Maybe she recovered because she took the over-the-counter drug, a different treatment. Maybe she recovered because 5 days have passed, and even if she didn't take any drug, she would have recovered. Right? There are different options here. And this evidence is ambiguous regarding what caused the recovery, because we only know that all these causes were there. We don't know which one led to the recovery. So even relatively simple outcome like this recovery creates a very complicated attribution problem. And this is a very concrete example, but it reflects to a much broader question in psychology, which is how people update their beliefs given new evidence. And in this regard, most research and theories about belief updating ask this question one belief at a time. So what happens is, for example, often research asks whether updating is rational, meaning we're trying to be accurate and we're proportional to the evidence we see, or whether it's biased by motivations we have, maybe by our prior beliefs, right? Confirmation bias. We want to keep our previous beliefs. Maybe other types of motivated reasoning. For example, it could be affected by our preferences. Maybe we believe what we want to believe. But pretty much almost all of this research, as I said, is focused on one belief at a time. So we test a specific belief, show some evidence, do some manipulation, whatever, and then test this belief again to see the posterior. And there is an important limitation here because although it was very productive and we learned a lot from this research, usually in real life context, as we saw in Sarah's example, the evidence could be explained by different causes. And there are many beliefs, not just one, that could that are related to how you interpret the information that you receive. So instead of focusing on single beliefs at a time, what me and my lab is doing is focusing on what we call belief systems, in which every specific evidence, like Sarah's recovery, is attributed across multiple beliefs that they can combine or can compete to explain it. And in that case, we need to look at many different beliefs, then see the evidence of manipulation or anything like that, and then test how all the three beliefs changed as a function of each other because they interact. I'll give you one example just for some intuition. One phenomenon in belief updating is called belief polarization. This is when two people start from pretty much the same point. They see the same evidence, but they update their beliefs to opposing directions. Okay, so their posterior belief is very different. And usually people interpret that as being irrational. People just believe what they want to believe, right? Because they saw the exact same thing and they updated their beliefs completely differently. But this is true if you look only on one belief, let's say this belief, okay? You only look at the prior belief here, and then you show the evidence, and the posterior belief is very different, and it looks irrational. But if we look at it from a belief system framework, this might not be irrational, because maybe this person, the blue one, for example, has different other beliefs that help them or make them interpret the evidence differently. I'll give a concrete example. Let's say that these are two physicians that saw a medical test, the outcome of a medical test of a patient. So they can see the exact same result. And maybe one concluded that the person has the disease, and the other one concluded they don't. And maybe it's not because they believe what they want to believe or avoid the evidence. Maybe it's because one person knows something else about the test or knows about another outcome of a different test or about the disease as other information and beliefs that makes them interpret the outcome differently. And I'm not going to get into politics at all and not describe this study in details, but I just want to show this as a proof of concept. We published this 3 years ago. This is a study that I did in my postdoc with Tora Waker's lab. And what we did, we examined belief updating about election fraud after the 2020 US election. It was in the US online. And we found empirically something that looked very strongly motivated. And what you see here is their preference, how much they prefer a specific candidate, and the x-axis. And then the y-axis, you see their updating of beliefs that fraud affected the election. Okay, the updating. If it goes up, it means they believe more in fraud after they see the outcome. And if it goes down, they believe less in fraud after they see the outcome. What we found was that when people win the election, their candidate wins, they believe that their belief that fraud affected the outcome decreases. And if they lose, it increases. Okay. Not only that, it's also correlated with their preference. Right? The more they care, the more they prefer their candidate, the more they increase their belief in fraud after a loss and decrease after a win. And this looks strongly motivated, okay? That people just believe what they want to believe. But we took this, and the key point that I want to make from this paper is that we developed a Bayesian model of unbiased belief updating. It knows nothing about your preferences, but it knows your beliefs more generally, not just about fraud, but about who should win and who can cheat and things like that, and I'm not going to get into it. And what you see in the dashed line is the model predictions, and it actually predicted the exact pattern. So even unbiased updating could explain results that seemed very, very motivated. Okay, this is the point that I want to make here, that what looked like motivated reasoning at the level of a single belief could emerge from rational attribution of ambiguous evidence, here the election outcome, across multiple possible causes. I'll go back to the treatment context, which will be easier probably for us. If we have a recovery okay, symptom improvement, is ambiguous evidence, like I showed you in Sarah's example. And we have different alternative explanations for that. We have the main treatment. Here it's the antiviral drug for COVID-19. We have the alternative treatment, for example, the over-the-counter drug. And we have natural history. 5 days have passed. And maybe she had COVID or she didn't have COVID, and there's some uncertainty here. And when I see, I have beliefs about each of these, and then I see the recovery outcome. And now I need to interpret this outcome and give credit to the different potential latent causes. Okay, I can say, okay, she recovered because of the main treatment, because of the alternative, because of natural recovery. Maybe she didn't even have COVID at all. Okay, this is a problem where I need, as a person reading that, I need to attribute the evidence across the different beliefs. So the key question that we wanted to ask is how people do it. How do people distribute credit in this medical domain across the possible causes? And we wanted particularly to see if alternative explanations influence treatment beliefs. Does the fact that someone may have recovered naturally affect how I update my belief about the main treatment when I see a recovery? Okay. So we tested this with data that we collected during the first months of COVID-19. This is why the Sarah's example was about COVID, which is not as timely now. But we collected data online, first month of COVID-19, April to June 2020. It was before there were any vaccines, treatments, or anything like that. We collected it online. After exclusion, we had 851 participants, and each one of them read vignettes, just like I showed you about Sarah, okay? But they could have read different vignettes. Each vignette described either a female or a male with specific symptoms that we manipulated to be 3 different levels, low, medium, or high. And each level means the severity of the symptoms that we describe, and they're linked to COVID-19. So it could be like a stomach ache, which is not very related to COVID-19, or like hospitalized and tested positive even, okay, or something like that. We told them that the patient is enrolled in a clinical study testing a new drug for COVID-19. This is the main treatment here. Again, no drugs at the time. Okay, when we ran this experiment, there were no approved treatments for COVID-19. Then we also said that this patient took something else. So either they took vitamins, or they rested a lot, or they took an over-the-counter drug like Sarah did. And then we showed them an outcome. Either the patient recovered, or the patient did not recover at all. Okay, symptoms stayed the same, or symptom disappeared. And again, the key question was, do alternative explanations influence treatment beliefs? Okay, do my belief about the main treatment, the antiviral drug, depend on what I think about the other option, the other explanations? Okay. And from a Bayesian model like that, what we would expect is that the more you believe in a competing cause for recovery, for example, natural recovery or the over-the-counter drug, okay, the higher you are on the x-axis on believing these other explanations, the less credit you should give to the main treatment, right? If I think that Sarah would have felt better anyway after 5 days, then knowing she took the drug and felt better after 5 days doesn't make me believe in the treatment more, okay? That's the point that that the models predicted, and we wanted to test if people actually do. There's another point here where it also matters whether they have COVID-19 or not, right? Because if Sarah doesn't even have COVID-19, then I cannot conclude anything about treatment for COVID-19 from this scenario. So the model predicts that the more likely it is that the patient really has the disease, the more credit you should give to the main treatment if the patient recovered. Okay, so here it's a positive correlation. And we wanted to see whether people, what people actually do in the treatment context. So first, we asked, did they take into account whether the person was likely to have COVID-19 in the first place? Okay, and again, the model predicts a positive correlation. And indeed, what we found here is that the more the symptoms were connected to COVID-19, the more people gave credit to the main treatment. Okay, so here they acted as the model predicts. Okay, there was a positive correlation. This is also true when participants, based on participants' beliefs, reported subjective beliefs, not just what we manipulated, the symptom levels. We also asked them how likely it is that this person actually has COVID-19. And if we use this data, we see that the more the participant believes the patient has the disease, the more credit they give to the main treatment as being effective against COVID-19. Okay, this was the first step. So participants did consider whether the patient is likely to have the disease or not. But we wanted to test if they also accounted in a Bayesian way, for the alternative explanations. The data show you the more you believe in an alternative explanation, the less you should give credit to the main treatment, right? If you think the over-the-counter drug is enough, you shouldn't give too much credit to the main treatment for recovery. But here, contrary to the Bayesian prediction, people seem to neglect natural history. Okay, this is belief about natural history, how likely it is that the person would recover only after 5 days, even without taking any treatment. Even if they believe this is an option here, they still gave the same credit to the treatment. Okay, so they just didn't take into consideration the possibility of natural recovery when they reasoned about whether the treatment works or not. Okay. Second, here, we want to see what happens with the alternative treatment. And again, the model predicts the same thing. The more you believe in the alternative treatment, the less you should give credit to the main treatment. And what we found is that, again, they neglected it. There was no correlation between the alternative treatment and the credit they gave to the main treatment. And not only this, if we looked at the reported beliefs of participants, how much they believe that the alternative treatment was effective for COVID-19, it was actually positively correlated with the main treatment belief, meaning that if you think that Sarah is going to feel better due to the over-the-counter drug, you also give more credit to the main treatment. Kind of a thinking of like either everything works or nothing works, something like that, okay? So either you give credit to all treatments or to none at all. So just to summarize this, what we found was some sensitivity to causal structure, right? Because they did consider whether the disease was likely. But we found weak, what's called explaining away, weak competition for credit as a Bayesian rational, normatively rational agents should do. Natural recovery was neglected, and they kind of shared credit assignment across the two treatments, the main and the alternative one. Okay, they kind of reinforced each other. The broader implication is the treatment beliefs may become self-reinforcing, because if people neglect the possibility of natural recovery, it means that if you get a treatment and get better, you just think that now you believe that the treatment works, and you don't think about other explanations of that. And without control groups, which we have in clinical trials, but we don't have right in real life, it's hard to know what caused recovery. I actually have an anecdote for that. Like when I went with my kid to the physician once, they gave him a drug. I went home. He felt better after a few days. And when I was there again, she said, the nurse asked me, did he take the drug? Did he feel better? I said, yes. And she said, oh, good. So it worked. And I said, I don't know. I don't have a control group. And she looked at me like I was crazy. But I think really that most people and physicians as well, like the caregivers, they don't think about, even if they know scientifically that we need clinical trials and stuff, if a physician or a caregiver gives someone a treatment and it works, and the patient improves, I think they will naturally attribute it to the treatment. It's just more salient, it's more clear, it's easier, instead of just thinking, wait, I don't know what would have happened if I didn't give them the treatment, I need to compare and things like that. So this could make ineffective treatments persist. And it could happen not simply because people ignore evidence or something like that, or irrational, but because evidence is ambiguous and it's hard to attribute it within a broader system, to attribute correctly, and you need to rely on your prior beliefs, which are not always correct. What we do now in the lab, the next step is to test how general this is, if it's just in COVID-19, because at the time, like binary thinking of either like we're doomed and nothing would cure this, or it's okay, everything cures this, was kind of common. So we want to see if this generalizes to other types of treatments or domains, medical domains, for example, in the flu, which is what we're doing now, Sapir from my lab is doing. And to see if we can characterize when it happens, who neglects alternative explanations, to what degree, maybe we can find individual differences that predict it. So this is what we're doing currently. Okay, so until now, I covered two topics. One was how expectations are generated, and the other was how treatment beliefs are updated. And this brings me to the final question, which is, can we harness treatment expectations and beliefs to improve clinical outcomes? And what I want to start with is something I think people here know, but just to put us all on the same page. If I take a treatment, not a placebo treatment, a real treatment, if I take a paracetamol pill, for example, I get better after a few hours, for example. And this improvement consists of different components. One of them is the direct pharmacological or physiological effect of the treatment, right? The active ingredient of the drug. One of them might be natural recovery dynamics, right? Maybe a few hours have passed and I would have felt better anyway. And the third component is the placebo effect, right? Placebo effect happens not only, we don't need a placebo for a placebo effect, right? If I take a real drug, I still have the conditioning and cues and context and expectations, and they affect the outcome. And this means that placebo effects are part of actual treatment effects. And if we can ethically enhance them somehow, okay, take this component and enhance it, we could potentially enhance effects of many different active treatments, right? Pretty much any treatment that has this component, which is most of the treatments, I think, without changing anything about the treatment itself, okay? Not changing the active ingredient, just changing everything around it. And one option to try and do that is to try and find, the best way to induce placebo effects. Like, do I need to do conditioning? What do I need to say? How do I need to say it? I need, for example, as we saw, right? I need the physician to be warm and to be competent, right? We have all this knowledge that we know. We can also try to find, to characterize the placebo responder, to see what personality traits or other factors determine whether a person is more likely to have a placebo effect. But this is actually was found to be quite challenging, and meta-analysis showed that we don't really have placebo responder, and the different studies find different characteristics. So it seems more complicated than that. And I think the reason for that, I want to suggest that the reason for that is that placebo effects are not a main effect. They're an interaction between who the person is, what the treatment is, and everything around it, what I call it the message, the context, the description of the treatment, what they hear about it, what they think about it. And I want to suggest that we need to change the question from who is the placebo responder to what message works for whom, or what do we need to do for a specific person to enhance the placebo effect for them today, now, in this context, okay? Because the same person might have a strong placebo effect in one context or one day and a lower one in another context, because there is an interaction, okay? So what our approach in the lab, I call it personalized placebo, is to try and find the way that we can tailor communication about the treatment in an individual way, to personalize it. So to use this part of the communication of a treatment as an intervention target, and try to personalize that to enhance the expectations of each person about each treatment in order to induce stronger effects. So what we're trying to do currently is to find which information we need to collect about the patient. It could be demographics, personality traits, beliefs, cognitive styles, many other factors. Find out to use that to create personalized treatment materials. And it's important for me to say at this point, we're focused on taking true information about the treatment and personalizing it, not inventing anything, not lying, doing it in a completely ethical way, just communicating about the treatment in a way that will resonate with the specific patient or specific person, okay? For example, one person might need to know the biological mechanism of a drug. Another person may just need authority, right? Need someone to tell him it's going to work. A different person might need a lot of information, some information to know about other people that it worked for, to know about clinical trials, to know about, there are so many different things that we can manipulate in that, or we can tailor with regard to that, without lying, again, not lying, just giving the correct part of the information or delivering the information in the correct format. What we're testing is whether we can do that in a way that will increase treatment expectations for each specific individual, because we hypothesize that if we do that based on the placebo literature, we will also enhance the actual treatment effect, because placebo effects are part of the treatment. Currently, we're at this stage, only focusing on treatment expectations. We're trying to build better rules and tools to increase treatment expectations. I will say carefully we want to increase them, but we don't want to increase them too much. I don't want someone who has cancer to believe the treatment is going to cure them tomorrow, because then it will backfire and nocebo effect and things like that. But we do want to increase expectations, at least to some degree. And we're working on that now, trying to see if we can come up with empirical rules scientifically grounded rules on how to do that. I'll give you an example. Let's say I tell you about this treatment, okay? Lidexa is a new topical cream that thousands now use for effective local pain relief. A review of posts in social media from more than 2,800 users found that 8 out of 10 reported clear improvement, often saying around 3/4 of their pain was gone. Users describe it as starting to work quickly and lasting for hours. People say Lidexa is very safe. I use it all the time and it really works. One person shared. This is one option. Another option to describe a very similar drug is Novocare is a novel topical cream designed for effective local pain relief in double-blind placebo-controlled clinical trials with more than 2,800 participants. These are the same numbers. It achieves an average 75% reduction in pain, with 80% of users reporting significant relief. The cream starts working within minutes and its effect lasts for several hours. With an excellent safety profile and FDA approval, Novocare is trusted by healthcare providers worldwide. We call the first one experience-based. So this description is more like, users, people who use it, what they report, what they think. And the second one, more evidence-based, right? With clinical trials, placebo, healthcare providers, FDA approval. And what we found was, as we expected, was that we can characterize who will be more convinced or will expect a better outcome from the first treatment compared to the second treatment. Okay, so first of all, we found the group effect where overall people prefer the evidence-based description, which is nice to know, at least for me. But also we found the interaction that we were looking for. So people who have higher trust in science and in scientists were more convinced or had higher expectations following the evidence-based treatment compared to the experience-based description. And there's a scale, a questionnaire that measures your thinking style, if it's more intuitive or more evidence-based. And people who were more evidence-based thinking style were more convinced by they're here, were more convinced by the evidence-based description, and people who were more intuitive were more convinced by the experience-based description. We run multiple studies currently to test different properties of the treatment descriptions and predicting different characteristics that could be related to that. I just wanted to show you this as an example. Another short example is about causal attribution, or what makes the treatment work. Roy from my lab, who is here, I think, leads this. And what we did here, we manipulated the attribution of how the treatment works. And luckily, we could do it with a TENS device, because it's true, we have different theories about how TENS device works on pain. And one option is to say that the treatment blocks pain signal. So it's an external distribution. This treatment just fixes the problem, okay? And this might strengthen beliefs in the treatment and may boost immediate response, right? You can trust that this works, something comes and just blocks your pain. But we can also describe it with internal attribution, saying that the treatment, the TENS device, activates endogenous analgesic processes, and then your body is part of the healing process. And this enhances, right, perceived control, self-efficacy, agency. You have agency on the process. And this may be better, the second one, for people who have, for example, higher self-efficacy beliefs. They need control, they believe in their body, they think it's good that it's for their body, etc. And in this case, this may also induce more durable and more generalizable effects, right? If my body healed me, then I can do it again in the next time that something happens, right? It's more generalizable, and it may last for longer because it doesn't really depend on the external treatment. It depends on me. So we ran this again online and tested treatment expectations, and the preliminary results indeed show that there are specific characteristics, such as desirability for control, self-efficacy, some interoceptive measures that predict preference for internal versus external attribution. Okay, to finish this part, which is the last part, I'm a basic scientist, okay? I did my PhD and my postdoc on very basic science questions, but being a placebo researcher kind of made me, it drives me crazy that placebo effects are not really used in clinical settings, right? Or not enough. They're kind of the enemy, right? As probably people here know. And I really wanted to come up with something that could be potentially implemented in clinical settings, okay? That could actually be used directly. And although I know that, if physicians will be more competent, and I think if physicians will tailor the way they discuss treatments with their patients, this could enhance the effects. I don't think it's practical. I don't think that I can change the way physicians worldwide, communicate treatments. I don't think it's a skill they have time currently. Most of them have time to gain. They have other things they need to do. They have less time in many countries, more patients and stuff. So I think we should try and use technology for that when we can. And luckily, in the last years, new technologies have emerged that could help us with that. So trying to scale up how we can use that, we're also focusing now on LLMs or AI and trying to see if we can use the patient information in a way that this is how I envision it. Okay, someone comes to the clinic, they provide the information we need. We're working on understanding what information, but I think we can expect patients to, invest time in giving us information if they want to get better. It's for their own benefit, and they have usually more time to devote to that. Then they go to the physician. The physician decides about a treatment. I don't touch that at all. We don't touch this part. But then I can have a tool, an AI-based tool that takes this thing, the information about the patient and the information about the real information without lying about the treatment, and combine them and create personalized treatment materials. This could be textual, like I just showed in our experiments, but it could be a chatbot, virtual reality. In 2 weeks, this probably new technology will emerge. If I'm also connected it to the talk before me, we could create a video of a figure explaining the treatment, and this specific figure can be tailored. It could be a older female, if this is what we need, or it could be a younger male, or whatever we need for this specific person, right? We can tailor that as well. And I think this could actually work if we find scientific rules that we can personalize based on them. And I actually thought at the beginning, I have to say that maybe LLMs are better than me in personalizing that. Maybe I don't need to test all the things I just showed you. Maybe, I'll give it to ChatGPT and the information about the patient, the information about the drug, and ChatGPT will be able to just tailor it better than me and convince the person. So we tried that. Ron from my lab led this effort, and we learned that they're not as good as we expected them to be. Sometimes it works, sometimes it doesn't. It can backfire. People could react badly to personalization. They could react positively. It's not clear exactly how he does it and whether it's the right way to do it. The format of the materials, like I said, chatbot versus text, etc. So now we're working on all of that and understanding that, with the aim to combine the empirically grounded rules that we know, like for this type of person, give an experience-based description. For that type of person, do an evidence-based external attribution, internal attribution, more details, less details, etc., and combine them with LLMs capabilities to scale it up and to automate things. And the vision there would be that, like we have personalized medicine, right? We fit the treatment to the specific person. I think we should also fit the placebo part, like everything around the treatment to the specific person, and then we'll have a real personalized treatment. Just to summarize all 3 parts, I think that to harness placebo effects ethically and effectively, we need to understand not only that expectations matter, which I think we already understand, at least I believe in this. We need to understand how they are generated, how they are updated, and how we can optimize them for each individual to leverage the interaction between the person and the context and the situation in a way that will benefit. I want to thank you all for listening, and my collaborators from the postdoc here, and my great lab members who actually do this research. Thank you.